presenter is Dr. Leython Williams of Athletico Physical Therapy. He's over there giving me the thumbs up. He's ready to go because we're late. He's a really good guy, easygoing, so he's cool with it. Leython Williams is a doctor of physical therapy and facility manager for Athletico Physical Therapy at their Lincolnshire facility. He is an expert in musculoskeletal function and rehabilitation as he uses his knowledge and creativity to best serve his patients to restore their function and decrease pain. Leython's mission aligns with Athletico's in providing progressive outpatient therapy through personalized care that emphasizes patient education and injury prevention. Leython is actually my physical therapist, as well as my husband's and my daughter's. PT is kind of a family affair in our house. He really does go above and beyond the call of duty. Leython sort of runs point for me. So when a person with pain contacts me and says, do you know a physical therapist that understands CRPS or EDS or fibro or whatever the case may be and lives in this area, I actually just contact Leython. And I say, okay, you know, not everybody understands this. Not everybody knows that you can't be touched this way or you can't be pushed this hard. Do you know somebody really good in this area? And he will run point and he will contact them and then get back with me. And so then I contact the patient and say, yep, call this person at this location, and it just works out beautifully. So within the Athletico chain, they have a lot of really knowledgeable physical therapists, and unfortunately I abuse our friendship because he does that for me, but it works out really well for the patient population. So I appreciate Athletico for that, and I really appreciate Leython for that. They may not know that I abuse him that way, but it works out really, they will now, and it works out really well for our paid population. And it does help us, you know, benefit more people, and that's my goal, and it's certainly his goal as well. So please welcome my friend and my physical therapist, Dr. Leython Williams.
First off, no worries, Gracie. Your secret's safe with me. Don't worry about I enjoy, yes, right, and the rest of the world, yes. I enjoy going the extra mile for my patients and friends because I enjoy what I do. I love being a physical therapist. I love being able to meet the needs of my patients and really restore functional ability. It's really a passion of mine. And I was talking to someone earlier that came by the table regarding loving what you do and not really having to work at all because you really enjoy what you do that much. It's really a love and a passion, and that's what I found in physical therapy. And with every patient that comes in, it's really more and more rewarding to me. And so, as Gracie mentioned, my name is Leython Williams. Indeed, I am a physical therapist and the facility manager of our Athletico's Lincolnshire clinic. It's really a pleasure and an honor to be here. A little bit about myself. I did my undergraduate studies at Central Michigan University. Played football there, fire up chips. Okay, all right, thank you. and then I matriculated here to Illinois, where I went to graduate school at Rosalind Franklin University of Medicine and Science, where I got my doctorate degree in physical therapy. And I stuck around. I've been working with Athletico since I graduated. I really feel that Athletico as a company really aligns with my views and my really approach in treating patients and patient-specific intervention. And then this is my family. As many of you in here know, yes, my lovely wife, please raise your hand, Blossom, please. Thank you, thank you. I like to start any presentation off with thanking my family. As many of you all know, and Dr. Hamilton spoke to it earlier, a support system is imperative. Having motivating factors in your life and really working towards really your goals, but beyond you. I mean, there's times when you don't want to keep going, and it's important to have a perspective of something greater than yourself. And my wife and my two daughters are those motivating factors for me. So I want to make sure I put them in my presentation because I think everyone in here can really resonate with having a motivation beyond yourself going through things. So And then, so thank my family, but then I also want to thank Gracie Jean and the Chronic Pain Advocacy and Consulting. Last year, or 2 years ago, I met Gracie for the first time. She walked into my clinic with her husband, Brian, in a world of pain. And instantly I knew that, were you? Chronic pain. Crying, yes, crying. Yes, crying. And I knew that I had to do something to help her. I knew that I wanted to do something to help her, and I wasn't going to let her leave our clinic without some type of answer, without some type of plan, without something that she can put her hands around and really take ownership of in therapy. And so over the past 2 years, I had no idea who she was when she walked in. And as I got to know her through treatment, through therapy, she became a friend. She told me so much about what she's doing here as far as chronic pain advocacy. I think it's a beautiful thing. She invited me last year as an exhibitor, and just from seeing people come by each table, good experiences from therapy, bad experience from therapy, it was all rewarding. It really all went into my understanding of chronic pain, chronic conditions, and also in my desire to really buff up the role of physical therapy in treating this patient population. So thank Gracie for all the work she's done. Many of you know of the work that she's done here in the conference and putting it together, making it run smoothly, but the work that she does behind the scenes and going on patient visits and advocating for patients in various ways that really goes unseen is remarkable. So thank you, Gracie. I've taken notice, and many people have. You've impacted so many lives. So keep on keeping on, all right? All right. So we'll get into the presentation. So we'll start with just a definition of pain. It's been defined by the International Association for the Study of Pain, that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describes in terms of such damage. I like this definition. I mean, there's no great, perfect definition of pain. You can't really describe or define what people are going through every day with chronic pain, but I like this because it touches base on both the sensory and the emotional experience involved with pain. I think that emotional part is really important because, I mean, think about it. Take, for example, heartache, right? All of us, sad to admit, but have experienced some form of heartache, right? Now with heartache, that's an emotional thing, right? Our heart has been hurt. We've been, really hurt deeply, and we have this emotional response. We're saddened, there's despair, but in addition, there's, maybe cramps in your stomach. There's this the sensation of your heart rate increasing. There's these physical, tangible changes along with the emotional response. And so I like how the sensory and the emotion of pain is coupled here. In addition to that, I like the potential tissue damage. As many of you know with chronic conditions, a lot of times that pain can't be detected. A lot of times it's unidentified when physicians are trying to pinpoint where that pain is coming from. And sometimes it's the potential of that tissue having some damage that is painful, right? The emotional stimulus there that causes some, hesitance or some increased muscle tension or really pain, right? Pain is always a subjective experience. As you know your pain more than anyone else, right? We try to objectify pain in so many ways, right? How many of you, just by a show of hands, how many of you have had the question, rate your pain on a scale from 0 to 10? Right? How many hate that question? Okay, all right. It's like, right, it's subjective. It's a way that we try, as healthcare professionals, we try to objectify it really as much as we can, but really what we're doing is trying to create a baseline for what an 8 out of 10 is for you, right? An 8 out of 10 for me and an 8 out of 10 for Gracie are gonna be different. But what that helps me as a physical therapist, as a healthcare professional, it helps me understand, okay, she walked in with 8 out of 10 pain. My goal is 2-3 weeks, decrease that pain by 2. So maybe we can get 6 out of 10 pain. I don't really care as much really what 6 out of 10 pain is to me as to her, but the 8 out of 10 has decreased by 2, so that's progression, right? So it's our way of really using that subjectivity to really improve our treatment. Everyone learns the meaning of pain through experiences, usually related to things that happen to us early in life, right? I mean, you think about from a very young age, baby, toddler, you fall, you hit something, you start to understand that's not good. I shouldn't do that. That's painful. That doesn't feel good. And then from there, experiences start to tell us, starts to inform us of what that pain is, what a 10 out of 10 is. To a person who's been shot before, right? That's a 10 out of 10 pain, I would imagine. I haven't been shot, but I would assume that's a 10 out of 10 pain, right? But a person who's never had real significant pain before, stubbing their knee at the edge of a table might be the worst pain they've ever had. So in their minds, that's 10 out of 10 pain. And so oftentimes they're describing to your patients, okay, 10 out of 10 may be, a significant cut or, your ER pain, right? 0 out of 10 is obviously the absence of pain. And then where in between that continuum can we really put your pain? But it's all referenced to explain that pain that you've experienced in your lifetime, really starting from a young age. And again, it becomes an emotional experience. No one has pain and smiles. You don't stub your toe at the edge of a bed and smile automatically, right? The first response is like a sadness, pain, anger, may drop some choice words, right? It becomes emotional automatically. So that emotion and that physical, again, are conjoined. And again, I can't stress it enough, significant stress, both physically and emotionally, in pain. Now, there are different types of pain descriptors. There are many, right? First, somatic pain, right? So there's the type of pain that's a little bit more superficial, right? If it's on the skin, it's the cut, right? The scrapes that we have, like the abrasions, if you will, that we get. And then there's also a little bit deeper as far as muscular pain, our muscle strains, the hamstring pull, that tension that we have. Those are considered somatic or a little bit more superficial. Then there's also visceral pain. Visceral meaning more inward, a little bit deeper. Many times, visceral pain can be caused by an activation of pain receptors from infiltration or compression to deeper fibers, whether that be a chest cavity, right, thoracic cavity or wall, the abdomen, or pelvic viscera, right? This is a little bit different. So an abrasion is much different than having that pain on a chest wall, different types of pain. It's kind of how we describe our pains. It's a little bit more somatic versus visceral. And then third, neuropathic pain, which many of you in here are familiar with that tingling, that burning, that sensation that you feel that, it doesn't feel quite right. They ask you to describe your pain and you're like, is it pain? I don't know if it's pain. It burns, it tingles, it's uncomfortable. Is it pain? Yes, it's neuropathic pain. It's caused usually by more compression on a nerve or really even over distraction to a nerve root as well. All right, and what we're all here for, this is a chronic pain expo. So diving into chronic pain a little bit. Chronic pain, it differs from acute pain in that, acute pain would be short-lasting. Think of acute pain as a knee sprain. You sprained your knee, right? You maybe, I won't get into technical terms, but maybe you were being very active and maybe sprained an ankle, right? That's going to recover, right? Depending on the level of the sprain, 4 to 6 weeks, 6 to 8 weeks, you're not going to have that pain forever. You're going to improve. You're going to get better. Chronic pain is a pain that it really lingers beyond the usual recovery period. Oftentimes it starts, right? Everything starts in an acute phase. We think it'll get better, but we start thinking that it's more acute when, 8 weeks have passed, it's a grade 1 ankle sprain, you're still having pain like you just twist your ankle. This is moving into maybe a chronic issue. This isn't presenting the way we expected. Let's take a closer look. Oftentimes, chronic pain starts there with the expectation of there may be something, and then you look up and there's months, there's years of this pain that hasn't really remitted at all. The other thing that I wanted to mention about about chronic pain, again, it's a little bit more subjective. It's not as easily clinically characterized as the acute pain. Usually acute pain is started with some type of trauma, right? Some type of, whether there was surgery and there's a post-op, and so you have this acute pain right away and it gets better progressively, or some type of traumatic experience, whether it was a fall, an accident, something that really precipitated the presentation of the patient. That's acute. Again, chronic is described by a discomfort that really lasts and lingers over time. And in addition to that, many times with chronic pain, and many of you know because I found that at these chronic pain expos, a lot of the individuals here are very, very learned and very, very aware of their chronic pain. I can't say that every patient that comes into my clinic is as aware and understands things on such a deep level as many of the individuals in this room. So many times people don't really understand what's happening. They don't understand the central nervous system and how there are two things at play. The allodynia, which there's pain with things that shouldn't cause pain, right? So the gentle touch onto your arm or your husband or wife touching your shoulder and just putting their arm around you is extremely excruciatingly painful, right? Well, that shouldn't be. That's a heightened alarm or heightened reactivity from the central nervous system that's making you receive that pain on a level that really shouldn't be. Many people would describe it as, our minds, our brains are tricking us, right? Because there's pain on a level that shouldn't cause pain. And then in addition to that, there's hyperalgesia, which the stubbing of the toe on the bed. There should be pain with that. There should be discomfort. That doesn't feel good. But that stubbing of the toe taking you back weeks, to recover from, that is a hyper reactivity or hypersensitivity that is really common in patients with chronic pain. In addition to these things, I think it's important to note that chronic pain is multifactorial. It doesn't only affect just our bodies physically, but it also starts to really delve into our personalities, our functional ability, and really our overall lifestyle. I really like this slide because it talks about the dimensions of chronic pain. Really, it starts with physical factors, right? Whether it's, we'll use that ankle sprain example, right? It starts with physical pain. Like my ankle hurts right now, it's painful, but I can separate my personality isn't linked to my pain, my lifestyle isn't linked to my pain, it's just pain that's there, but I'm still doing what I gotta do. But as time goes on, throughout that continuum, you start to see psychological changes, right? Now that pain that I thought was gonna go away in 6 weeks is 6 months. The pain hasn't let up. Now I'm anxious. Now I'm depressed. Now I am really struggling with understanding, how do I get through this? Am I gonna get through this? Doctors aren't providing me with answers. My friends don't understand. My family, I can't talk to them about it because whenever they come near my ankle, I'm super guarded, I'm jumping back, and they're like, what's wrong with you? What's the problem, And so we start to kind of become lonely, start to become a little bit hostile, right? So the family members that are like, hey, Megan, why are you acting this way? Like, you look fine, right, Gracie? You look good, right? You seem great. What is your deal? What do you mean I look good? I feel terrible. We become hostile, we become angry. And so these are factors that really, as physical therapists, we deal with as well. I think a multidisciplinary approach to healthcare is important. But as physical therapists, patients walk in, they could walk in with just the physical, pathological part of it, where they just have pain, but they're optimistic, they think they're great, they're happy. They could be walking into the psychological part where they're very anxious and depressed and it's hard, and we gotta kind of help them cope and come out of that and have some confidence in therapy. Or they may be further along, this might be a 5-year process or more, and they're very lonely. They've cut off different people in their lives. They've really secluded themselves, and they've really, really isolated their lifestyle. And they look up and they're not going out for much aside from their patient visits, you know? And so as physical therapists, it's important for us to listen to our patients, to be aware of where they are on this continuum, and to treat them accordingly, and to listen and be thoughtful and open to wherever they are on this continuum. So physical therapy, we touched on it briefly. Now, what to expect? There are so many myths out there about physical therapy, and I heard a lot of them even at the table this morning and last year. People, many patients having negative things to say about physical therapists, and great things, right, Lori? I've heard so many patients say great things about and just raving about their physical therapists and their experience in physical therapy, and it does my heart good to hear that, because there's so much we can do as physical therapists to really impact change in the lives of individuals with chronic pain. But it also impacts me well to hear the bad things, because I think, and I'll say this a lot through this presentation, but I'm gonna say it first here. I think it's imperative as physical therapists that we shift. There needs to be a mind shift amongst us, because there are many great physical therapists. So I don't want to, disregard those. But there is a place right now where a lot of physical therapists are so textbook and so manual. And manual is great. I do a lot of manual therapy, but so textbook, so manual, so focused on their goals for the patient that they're not as tacit. They're not as understanding, they're not as empathetic, they're not as graded in their treatment progression, and it's really putting a bad vibe out there for a lot of people, and it's really turning a lot of people away from physical therapy. And even the research shows that physical therapy is great, but the research needs to be a little bit more specific on what that therapy is, because there's good and bad of anything. There's pushing your patient past their threshold and making their symptoms worse. And there's helping your patient gain confidence and pushing back the envelope safely so that they can do a little bit more until they look up and they're like, wow, I had no pain all weekend. And that is where we need to be as physical therapists, and listening to our patients and understanding our patients, empathizing with our patients, so that we indeed are doing them a service and not a disservice. So that's my little platform. I'll stand on it. I'll say that multiple times in this presentation, but that's really a big passion of mine, because I think there definitely needs to be a mind shift, and there are many therapists that have shifted, but I think there's more to come that need to. One myth number one: physical therapy will only make my pain worse. How many people have that thought? Have that thought that physical therapy will only make my pain worse? Okay. How many currently have that thought, like now, like today? Greg. Greg's a patient of mine. Really, Greg? Really? Well, so this is one of the things I get most often. One, because I'm a larger guy, so patients walk in and they're like, "You gonna do my therapy? Gotta go," or "Where's the next closest this way?" But please don't confuse with a therapist's size with a therapist's skill, because there are large therapists, bigger guys like myself, and there are that have a skill set to really be able to benefit you in therapy. And there's small ladies, like very small, like Jean size, right, Jean? that are. You were an OT. Jean was an OT. There are a lot of therapists small that have a skill set that can handle you in ways that you would have never guessed. So don't kind of judge the book by the cover, if you will, when you walk into a clinic. And before that, again, another soapbox, make sure you do your due diligence in finding out about this therapist that you're going to be treated by, to make sure that they're comfortable treating chronic conditions. Don't just walk into any clinic and ask for the next available therapist, right? That's why I love when Gracie contacts me about locating a therapist in certain regions, because I like to do that due diligence for the patient to make sure they're in the hands of somebody that knows what they're doing with this patient population. But yes, physical therapy will only make my pain worse. Not true, okay? Not true. There was a survey that found that 71% of people thought that physical therapy, who never visited physical therapy, prior to them ever going to physical therapy, had negative preconceived notions about what physical therapy would be and thinking that it would make their pain worse. That number dropped significantly after these patients had a week to 2 weeks of physical therapy. The goal of physical therapy, now we talked about the central nervous system and being, hyperreactive and, being in that alarm state. And so early on, doing anything, right, blowing on your hand may cause increased pain, right? Because the alarm state is so high. However, progressive graded exercise over time will decrease your symptoms. Okay, that is the goal of physical therapy, to decrease your symptoms. Now, if we stop at day 3 and you say, hey, did physical therapy help or not? The likelihood of you saying, it made me worse is high. We stop at week 3, you know what? I'm actually doing a little bit better. So physical therapy will make you get better, but sometimes the pain intensifies before it decreases. Physical therapy is only for acute injuries and accidents. Not true. The whole point of this is prevention is very key, okay? Physical therapy is really imperative to prevent conditions from becoming chronic, right? It's not only for acute, it's not only for right after an accident, but even a patient with CRPS for 5 months. Early intervention, early physical therapy will help that patient with strength, with range of motion, with functional ability, so that CRPS isn't what it, and 2 years later, that CRPS isn't what it would have been without therapy. So it helps decrease that progression. It helps improve your functional ability. Will it just eradicate every symptom that you ever had? It can. Does it always? No, but the goal is progression, not necessarily perfection. So if I was up here on a soapbox saying physical therapy is the cure-all, it fixes everything, please ask me to leave, but I'm not saying that. I'm saying that physical therapy can be very, very beneficial for everybody in here on some level. Will it cure every ache and pain, every symptom? Maybe, maybe not, but it will improve your condition if done right, okay? My doctor says that surgery is my only option. Again, false. Many times physical therapy is used as a conservative means to avoid surgery. There are conditions where, surgery is indicated, and for those, I'll applaud the surgeon for, do your thing, but I would much rather you try physical therapy, conservative means first. It's evidence-based, to try physical therapy to try to decrease some of those symptoms before you just plan to do surgery, because with any surgery there's complications, potential complications and potential problems that come along with that. So surgery avoidance is really the best bet. Any healthcare professional can perform physical therapy. How many have heard this? Okay. Now, everybody, with all due respect, everybody is not good at everything, right? So I wouldn't go trying to inject a corticosteroid shot into a patient's shoulder, because that is not what I have been licensed to do or skilled in or educated in for 7+ years, right? I've been educated in physical therapy, musculoskeletal conditions, movement patterns, quality of motion. That is my skill set. And so it's important that you end up in the hands that you're supposed to be in and not just have a catch-all of a healthcare professional. I think any good healthcare professional knows their limitations and knows when to refer you to somebody that's appropriate. I can do physical therapy all by myself. Why do I need to come in? Again, it's in the myth column because while your participation in your rehab program is imperative and important and welcomed, it's very important for you to have that guided practice, that education, that expertise from a healthcare professional, from a physical therapist, I should say, as opposed to just thinking you'll do it by yourself. Because in many conditions, the pain is so great, there's a lot of things you wouldn't do by yourself, and you sometimes need somebody to do that passively. So have them do it while you relax, or really kind of motivate you that you really can do it, to give you extra confidence. Sometimes you're not really there on your own, and that's chronic pain, acute pain, that's any pain. Sometimes we need people to push us. Physical therapy isn't covered by insurance. Now, insurance is a buzz topic these days. Now, most insurance providers do cover some form of physical therapy. I have not had a chronic pain patient that has had issues with getting any coverage with physical therapy. Now, oftentimes the problem is the patient really not getting to where we want them and then insurance cutting them off. That's been more of a problem. And real quick, my advice there, many times if you do a little break in the care, so say a patient's coming in, the patient has MS, but they're being seen for a shoulder problem, right? And so we've worked together for 3-4 months, and we've seen great gains, and we're starting to plateau, and the insurance company's like, you know what, I need to see more improvement, I'm not gonna keep covering this. Sometimes if you do a break in the care, right, like 30 days or so, and then the patient comes back in with a different diagnosis, because you can really justify MS, physical therapy for a patient with MS, really lifelong. I mean, there's a lot of different sensory deficits, strength deficits, things like that we can always justify. But sometimes if, hey, maybe it's not shoulder, but this time, it's neck or it's back, or something else that isn't quite, maybe we're working on balance issues or sensory deficits and such. Start out with a new diagnosis and then continue your plan of care that way. I am a big advocate on independence in your home program and taking ownership of what you're doing, but I do think that having a break in the care can be helpful. How can physical therapy help? Well, I've kind of jumped into some of this stuff already, but starting with education, right? Managing your pain. Physical therapy can help you understand how that pain occurs, having those conversations with your patient about the central nervous system and what's happening and why do you feel the way you feel, why does the lightest touch in the world make you feel like you want to jump through the wall. Having those conversations on, hey, that's normal within your normal of chronic pain. A lot of people are going through that. Your pain is validated. I understand where that's coming from. But in order to kind of desensitize you, there's some things that we can do in therapy to kind of help that. Having that conversation with the patient is huge. And then ADLs, activities of daily living, being able to help the patient, first of all, educating the patient on, hey, you can do certain things. I know you feel like you can't. It may hurt you physically, but it's not hurting your body. The arm is not being damaged by doing this motion. It may not feel good, but it's helping you to do it. Having those kind of conversations are also important in education. Strengthening and flexibility exercises. I touched on graded exercise. Graded exercise is huge. Graded exercises basically mean that you start at a certain point, a low intensity, low level exercise regimen, and it progresses gradually along the patient's progression. So you don't start off, all right, back to the wall squats, 3 sets of 10, go for it. No, you say, let me see how you stand up from the chair. Let me see you go from the chair and stand up. Okay, how did that feel? All right, let's try 3 of those and let's just focus on the mechanics with that. We're not gonna tire you. This isn't about, breaking any records. This is about focusing on your quality of movement, not necessarily the quantity of reps. So graded exercise is huge for the chronic pain population. And really, patients in general. What patient would you bring in and just have them max out on everything? You wanna start with where they are and progress gradually. And then manual therapy is really important in desensitization. A lot of, really the point of manual therapy is improving range of motion, decreasing pain, and a lot of this includes specific gentle hands-on techniques. Kind of hard to really describe them. It's much more easier to show you some manual techniques, but just sometimes putting your hands on the patient, one is really good at getting some confidence and making sure they're comfortable, and then moving their arm gently can show them, okay, my arm can move that way. It starts with some things like that just to start gaining confidence. The last one was posture awareness and body mechanics instruction. That's huge because a lot of times pain will put us in poor posture, right? So if our neck is painful, we're kind of hunch our shoulders like this. And if we stay like this too long, eventually we have issues in our back, and then our back starts hurting. So what do? We try to compensate that. We go a little further. And so it changes our whole mechanics, right? Think about this. If I have good posture and I raise my arm up, I got good range of motion. If I do this, see how that changes? So sometimes it's just the posture that can be improved and improve your range, right? This looks like I can't move my arm, but I stand up and have good posture. Look at that range of motion improve. Okay. All right. Any good physical therapy regimen starts with a thorough evaluation. Again, back on my soapbox, making sure you're contacting and doing your due diligence with finding a physical therapist that is skilled in treating chronic conditions, that is comfortable, skilled, and experienced treating chronic conditions, okay? That a good physical therapist will ask specific questions. That therapist will ask you your pain location, its intensity, what makes the pain decrease, what makes it increase, and other questions. The physical therapist is trying to get a clearer picture of your condition so that he can individualize your treatment plan according to what impairments you have. Not according to what the last patient with knee pain or neck pain had, but according to what Janie has, okay? That a good therapist is going to ask about your symptoms. Again, for the same reasons, trying to individualize and make your treatment plan specific. And here in Athletico, we fill out a lot of pain and function questionnaires. We have our patients fill out one when they come in at initial evaluation, and then we have one about midway through, and then one at the very end. And it kind of helps us kind of stay abreast on how that patient is progressing. If your score is the same as it was if your initial evaluation score equals your 3-week mark score, and that tells us, hey, your patient's not getting better. Even if the patient sometimes might say, I feel great, I feel like I'm improving, but sometimes that score would really indicate that functionally there's something missing. And so I don't just rely on the number, I rely more actually on the patient subjective response, but I kind of fuse the two, like, okay, you're feeling better, but functionally you still have this fear avoidance, you still have this lack of confidence in yourself. How can we make them kind of align? How can we make your feelings of improving and your functional progress come together? And we perform tests and measures with our patients to see kind of what movement patterns exist and how we can improve those movement patterns. Then observation, really key. Like I said, observation is what's going to tell me that patient's posture is poor. It's going to tell me that, where that range of motion is. It's going to tell me a lot of things about the patient's strength. Before I even put my hands on that patient, I can see a lot of deficiencies in their mechanics just through observation. And the thorough evaluation is going to, the patient or the therapist is going to ask about your x-rays. A lot of times there's capability to see MRI results, x-rays in our clinics, but sometimes there isn't. But a therapist is going to at least inquire about those x-rays, that imaging, to see kind of what are we dealing with. Your subjective history says one thing, but let me just look at where the impairments lie on your skeletal system. I want to see, let me take a look at what's going on. What is that MRI reporting? And a good physical therapist will work with your physician to provide the best diagnosis and the best treatment for your condition. Other considerations. The first one is patient interaction. I think that is huge. I think having that initial evaluation, and even every appointment where you have those moments where you sit down with the patient or stand up mid-exercise with the patient and you're asking the patient, talk to me. How you feel? What's getting better? What's getting worse? How was your weekend? What can I do as a therapist to better serve you? How are you doing? You know, having those interactions with the patients are important, and not just putting a patient on something and walking away with your back turned and coming back when they're done. But that helps the trust from a patient, and that helps their belief in getting better. You'd be surprised at just spending moments with a patient. Just, you know, you may have a couple patients going at one time, but just you as a therapist, what I found, going back and forth between patients personally makes them feel like they have better care than if I'm one-on-one with one patient and have a rehab aide working with the other one, and my back's turned to the patient and I check in with them before they leave. The patient would much rather have that therapist engaged with two patients at once, individualized care with two patients because it's the therapist who set the treatment plan along with your goals, than to just pass things off to a rehab aide and say, oh, go for it, you know? So trust and belief through patient interaction every visit, not just that initial evaluation, is important. There's no small success in physical therapy. Physical therapy, I believe, should appreciate every success, whether that's an hour or two without pain when you had pain consistently for 24 hours, whether that's being able to walk a block when you couldn't walk a half a block, whether that's being able to arise to stand 3 times when you weren't able to do it 5 weeks ago. Every success is a huge success, and should be celebrated as such. There's no room for, oh, okay, well, let's get you to 10. No, let's focus on, she just did 3. Let's celebrate the 3 she did, because she couldn't do any 2-3 weeks ago. So every success is celebrated. We talked a little bit about the desensitization through massage, stretching. There's different manual techniques, even modalities that often can kind of help desensitize, kind of bring that hyper reactivity and sensitivity of the central nervous system down a bit. And then again, low intensity exercise would begin with the low end and kind of work our way up according to the patient's progression. In addition to that, another good thing to do in physical therapy is that, say there's CRPS that's affecting the right elbow, right? Now, physical therapists kind of want to go to the point of pain and work on that and make it better. That's kind of how we're geared to think. But even just working the shoulder, my elbow's not moving, my shoulder's moving. But I'm improving that patient's circulation, the patient's confidence, ability to move just by moving the joint above it, right? Or you don't want to move the elbow, that's fine, let's move the wrist. Working on the limb as a whole, or even on a non-painful side, just doing some motion can kind of help with that patient's confidence. Prevention is key. Physical therapists can work with you to develop strategies to prevent chronic pain, such as 1, keeping up with as many normal exercises as possible, avoiding inactivity, improving posture, what you talked about, and performing exercises to improve and restore your sense of the involved body area, kind of what I mentioned. Moving the shoulder, moving the wrist, moving other joints as opposed to just focusing on the affected area until that patient feels comfortable. And then education, learning about your condition. I was going to go through a little case that I had from real life experience, but I'm actually going to skip this because I'm running short on time. So I'm going to speed through the next few here. I was just basically going over, Ashley's not a real patient, it's just HIPAA, HIPAA, in regard to HIPAA rules and laws, I just made up a name, but it's a patient that I've actually had, and I was taking you through her treatment progression. I'll go straight to take-home notes. The pain can be in the brain, central nervous system, but it's not in the mind, meaning that though the pain does affect the central nervous system and it kind of throws things off and makes many patients hyper-aware, it's valid. It's real, and you are validated, and don't feel that just because that pain can't be pinpointed or the injury can't be pinpointed by a physician, that pain is less valid. That pain is valid. It's in the brain, but it's not in the mind. Again, your pain is real. Your body is created to move. We have these amazing natural medicine cabinets that are in our bodies. We have endorphins in them. And so when we move, and release endorphins, it helps us actually decrease our pain. So being less inactive and sedentary actually helps us decrease pain just by moving, just by motion. Final thoughts. I'm going to have a real-life patient come forward. This is Greg Weinstein or Stein? I always back and forth. Okay, Weinstein. Greg's going to come up with his brothers, and he's going to share a little bit about his experience in physical therapy with Athletico. He's a current patient of mine, and these are his brothers. They're triplets, if you couldn't tell.
Thank you, Leython. I just wanted to bring up my brothers to illustrate a point. The point is we're 1 in a million. That's basically the genetic odds of having identical triplets. Thank you, Mom. But I also wanted to bring up the point that Leython, as a physical therapist, is 1 in a million. Now, I've had probably 15 years. Thank you, guys. You guys are very good looking. You can go. Probably had 15 years of different sorts of physical therapy. I was diagnosed in 2001 with MS, so I am you guys. I have chronic pain all the time. And what Leython does is different because just look at him. His smile's infectious. He brings about a positive attitude, which is what we need, because every day when you're in pain, it's so difficult to get through the day that you need somebody who's proactive in making sure you do the right things. And I am very fortunate to have found somebody like Leython who's able to do that for me. Because let's all remember here, pain's only for those who are living, okay? So whatever it is that you can do, whether or not if it's walking, stretching, biking, whatever it is, just do it to the best of your ability and be proactive. And just wanted to thank Leython, and I'm sure if there's any questions for him, I'm going to take Doug's phone back now, just so you saw that.
Thank you, Greg. Thank you. Thank you. And thank you all. These are my references, and that's my contact information. If any of you are in the area and are interested in coming in for physical therapy, love to have you. It's my time, so thanks for your attention.